My name is Dr. Katherine. I have spent over 28 years in clinical geriatric medicine and neuropharmacology, and I am going to walk you through the 9 most common medications quietly and invisibly eroding memory and cognitive function in adults over 60. We are going from the most commonly overlooked all the way to number 1, which is not a single drug at all, but a pattern affecting millions of seniors right now, that mainstream medicine is not communicating clearly enough for people to actually protect themselves. Before we go further, please understand something important. I am not telling you to stop your medications. Do not do that without your physician. What I am telling you is that you have every right to understand what is entering your body and to advocate for the health of your brain with the same urgency you would bring to any other vital organ. Knowledge protects you. Silence does not. Drop a comment right now and tell me your age and what medications you are currently taking. I read every comment personally, and your experience may be exactly what someone else watching today needs to hear. Number 9 is something that right now is sitting in the nightstand drawer of tens of millions of people, and almost none of them have any awareness of what it is doing to their brain while they sleep. Diphenhydramine. If you have ever taken a Benadryl to fall asleep or reached for anything with the word PM on the label, a nighttime pain reliever, a nighttime allergy product, a nighttime anything, you have almost certainly taken diphenhydramine. It is inexpensive, it requires no prescription, and the packaging presents it as completely benign. Here is what it is actually doing inside a brain over 60. Research published in the Journal of the American Geriatric Society found that older adults using diphenhydramine regularly demonstrated substantially elevated risk of cognitive decline, with neuroimaging studies showing measurable volume reduction in the brain regions most directly associated with memory formation. This is not temporary grogginess. It is physical change in brain tissue accumulating over months and years of routine use. What makes this particularly dangerous is how completely invisible it is. Diphenhydramine is the active ingredient in dozens of products never marketed as antihistamines. Anything labeled PM, nighttime relief, or sleep formula almost certainly contains it, and the person taking it every night has no idea they are administering an anticholinergic medication to an already acetylcholine-depleted brain. For allergy management, ask your physician about second-generation options like loratadine or cetirizine, which do not cross the blood-brain barrier in the same way and carry dramatically lower cognitive risk. Number 8 is one of the most chronically overprescribed medication categories in the world, and the cognitive consequences of long-term use are something that most patients are never warned about. Proton pump inhibitors, known as PPIs. If you take a daily heartburn or acid reflux pill, there is a significant probability it belongs to this class. These medications were designed for short-term use, typically 8 to 12 weeks, to address specific acute gastrointestinal conditions. What almost no one explains to patients is what happens when they are taken indefinitely, which is exactly how the majority of older adults take them. Your stomach acid does not only break down food, it is essential for extracting and absorbing vitamin B12 from everything you eat. Suppress stomach acid chronically and B12 absorption falls, often silently and without obvious symptoms for years. Vitamin B12 deficiency is not a minor inconvenience. It is directly and clinically linked to memory impairment, depression, peripheral nerve deterioration, and a pattern of cognitive decline that resembles early Alzheimer's disease so closely that experienced clinicians have genuinely confused the two. A major study published in JAMA Neurology, examining data from over 73,000 adults aged 75 and older, found that long-term PPI users faced a 44% higher risk of developing dementia compared to non-users. Research has additionally linked PPIs to potential acceleration of amyloid beta plaque accumulation in brain tissue, one of the defining pathological features of Alzheimer's disease. If you have been on a PPI for longer than 3 months and no physician has ever discussed a strategy for reducing or stopping it, that conversation is past due. If you have a genuine medical reason to continue, ensure your B12 and magnesium levels are tested at minimum annually. Number 7 is one that frustrates me professionally in a way few things do, not because the underlying condition it treats is not real, but because of how rarely patients are told the complete truth about what they are agreeing to. Oxybutynin, among the most commonly prescribed medications for overactive bladder, is simultaneously one of the strongest anticholinergic drugs in routine clinical use today. Overactive bladder is genuinely disruptive. It disturbs sleep, creates anxiety, limits social participation, and meaningfully reduces quality of life. When a physician prescribes something that promises relief, of course the patient accepts it. What almost no physician explains is that oxybutynin does not remain in the bladder. It crosses the blood-brain barrier with remarkable efficiency and directly suppresses the acetylcholine systems your brain depends on for memory formation, learning, and cognitive processing. Research has documented measurable volumetric reduction in the hippocampus, the brain's central memory processing structure, in long-term anticholinergic users. Not mental fog as a side effect. Physical, structural, measurable reduction in brain tissue. A comprehensive study published in the British Medical Journal found that seniors using strong anticholinergic medications, including oxybutynin, for more than 1 year, faced a 49% higher risk of receiving a dementia diagnosis, nearly 1 in 2. And the profound tragedy embedded in that statistic is that the early symptoms, forgetting appointments, misplacing objects, losing words in the middle of sentences, are virtually universally attributed to normal aging. The medication is never questioned. Newer bladder medications, such as mirabegron, operate through an entirely different pharmacological mechanism and carry significantly lower cognitive risk. If you are currently taking oxybutynin and have noticed changes in your mental clarity, please bring that specific connection to your physician by name and ask directly about alternatives. Number 6 requires care and genuine empathy, because I know this category of medication has meant something deeply personal to many of the people watching this. Benzodiazepines, Valium, Xanax, Ativan, Klonopin. These drugs have provided real relief to real people managing severe anxiety, panic disorder, and the kind of insomnia that makes sustained functioning impossible. I am not dismissing what that relief has meant. What I am asking is that you hear what extended use does to the aging brain based on the evidence available. A longitudinal study tracking over 8,000 seniors across a 6-year follow-up period found that those using benzodiazepines for more than 3 months carried a 51% increased risk of Alzheimer's disease. Long-acting formulations carry the highest risk because they accumulate in fatty tissues, including brain tissue, over extended periods of use. The neurological mechanism involves neuroplasticity, the brain's capacity to form new connections, encode new information, and maintain the dynamic cognitive flexibility that underlies memory, learning, and emotional regulation. When GABA is chronically amplified by these medications, the brain begins reducing its own natural activity in compensatory response. Cognitive flexibility deteriorates. Memory encoding slows. And because discontinuing benzodiazepines abruptly can precipitate severe withdrawal symptoms, including rebound anxiety and insomnia far more intense than the original presenting symptoms, patients find themselves unable to stop even as the medication contributes to their cognitive decline. Never stop benzodiazepines without medical supervision. The taper must be slow, structured, and carefully monitored. Alternatives worth discussing with your physician include cognitive behavioral therapy for insomnia, which has strong and sustained clinical evidence, and in appropriate cases, low-dose melatonin or magnesium glycinate as gentler ongoing supports. Number 5 demands precision in how I present it because the medication itself has saved and continues to save lives, and that fact is not in dispute. Statins. For many adults over 60, statin therapy is appropriate, evidence-based, and the cardiovascular benefit substantially and clearly outweighs any cognitive consideration. I want that stated clearly, but there is something that most cardiologists do not discuss in the context of brain health, and you deserve to know it. Your brain is composed of nearly 60% fat. Cholesterol, far from being the pure villain it has been characterized as in cardiovascular medicine, is a structural requirement for neurological function. It forms the myelin sheath insulating your nerve fibers, participates in synapse formation, and is essential for the speed and reliability of neural signal transmission. When systemic cholesterol is aggressively reduced, there is a threshold below which the brain does not have the raw materials its cellular architecture requires. The FDA updated statin labeling in 2012 to include memory loss and confusion as recognized potential side effects following review of thousands of adverse event reports. A 2023 analysis in Frontiers in Aging Neuroscience found that adults over 70 using high-dose statins for more than 3 consecutive years showed measurable increases in mild cognitive impairment compared to non-users. The clinically important distinction is that not all statins carry equivalent cognitive risk. Lipophilic statins, including simvastatin and atorvastatin, penetrate the blood-brain barrier more readily than hydrophilic statins, such as pravastatin and rosuvastatin, which have demonstrated significantly less cognitive impact in comparative research. If you are experiencing brain fog or memory changes on statin therapy, ask your physician specifically whether transitioning to a hydrophilic formulation might preserve your cardiovascular protection while reducing cognitive impact. Also ask about CoQ10 levels. Statins deplete this compound, which plays a critical role in cellular energy production throughout the brain. Number 4 surprises virtually every patient I present it to, because amitriptyline is almost never discussed as a psychiatric medication in modern clinical practice. It is prescribed for nerve pain, chronic migraine prevention, fibromyalgia management, and insomnia, specifically because its sedating side effect is repurposed as a clinical tool. What patients are almost never told is that amitriptyline carries one of the highest anticholinergic potencies of any medication still in widespread use. Its affinity for the muscarinic receptors, where acetylcholine performs its cognitive functions, exceeds many drugs specifically classified and marketed as anticholinergics. A landmark study in JAMA Internal Medicine following over 3,400 adults aged 65 and older across a 10-year period found that high cumulative anticholinergic exposure, with amitriptyline among the primary contributing medications, was associated with a 54% greater risk of dementia diagnosis. What I find most clinically troubling is the invisibility of the harm. There is no dramatic signal. There is a slow and relentless erosion. Word retrieval becomes effortful. Sequencing complex tasks requires deliberate concentration. The ability to hold multiple threads of thought simultaneously diminishes. And because it happens gradually, it is attributed to age for years before anyone considers looking at the prescription. For nerve pain, duloxetine and gabapentin carry dramatically lower anticholinergic burden. For sleep, very low-dose doxepin has a more favorable receptor profile. For mood, modern SSRIs represent substantially safer options for aging brains. Number 3 requires your complete attention, because what I am about to describe happens every single day in care facilities, memory units, and hospitals, and the majority of affected families never learn it is happening until significant and sometimes irreversible harm has already occurred. Antipsychotic medications were developed for serious psychiatric conditions, including schizophrenia and bipolar disorder with psychotic features. They carry significant side effect profiles that were considered acceptable given the severity of the conditions they were originally designed to address. Today, they are routinely prescribed off-label to elderly patients who are confused, agitated, restless, or behaviorally challenging in understaffed care environments. Not because those patients have psychosis, because medication is faster and simpler than individualized behavioral intervention. The FDA issued a black box warning about this specific practice over a decade ago, citing elevated risk of death in elderly patients with dementia-related behaviors given antipsychotic medications. The prescribing has continued regardless. A 2022 study published in The Lancet Healthy Longevity, tracking over 25,000 older adults, found that seniors given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even among individuals with no prior dementia diagnosis at the time of prescription. Antipsychotics suppress dopamine, the neurotransmitter governing motivation, executive function, movement coordination, and memory consolidation. Chronic dopamine suppression in aging brain tissue produces flattened emotional response, slowed thinking, impaired memory processing, and accelerated neurodegeneration. If someone you love in a care setting is receiving these medications for behavioral management rather than documented psychosis, ask why directly and in writing. Ask what non-pharmacological approaches have been tried and what the plan is to discontinue. Number 2 receives far less public attention than it deserves, and people are being harmed by that gap every day. Paroxetine, sold as Paxil. When most people hear SSRI, they associate it with the modern, better-tolerated generation of antidepressants. For most SSRIs, that characterization is accurate and fair. Paroxetine is the critical pharmacological exception within its own class. Unlike sertraline, escitalopram, fluoxetine, and virtually every other SSRI in routine use, paroxetine carries significant anticholinergic activity, a property that separates it from every one of its chemical siblings and places it in a risk category far more similar to the older tricyclic antidepressants than to the modern SSRI class it is classified within. A comprehensive 2021 review in Frontiers in Psychiatry found that elderly patients on paroxetine demonstrated measurable declines in short-term memory and verbal recall within the first year of treatment, declines that were not observed in patients taking other SSRIs at comparable doses. The American Geriatric Society has placed paroxetine on the Beers criteria, the evidence-based official list of medications considered potentially inappropriate for older adults, specifically citing this cognitive risk profile. The deeply frustrating dimension of this is that paroxetine is frequently and specifically prescribed to older adults for anxiety and depression, the exact population for whom it poses the greatest neurological risk. If you are over 60 and currently taking Paxil, ask your physician whether transitioning to sertraline, escitalopram, or another SSRI with a cleaner anticholinergic profile could provide equivalent antidepressant benefit without the cognitive burden. Most patients transition successfully with appropriate tapering and support. And now number 1. I told you at the beginning that this would not be a single medication, and I want to explain exactly why. Because this is the most important thing I will say in this entire video, and the thing I most want you to carry with you when this is over. Every medication on this list, taken in isolation, might produce only mild or barely perceptible cognitive effects in certain individuals. Some brain fog, a little more forgetfulness. Easy to attribute to aging, easy to dismiss. But here is what happens in the actual daily reality of older adults living with multiple chronic conditions managed by multiple specialists who may not have full visibility into each other's prescribing decisions. Let me make this concrete. Consider a 73-year-old woman managing her health responsibly. She takes a PM sleep aid nightly, as she has for years. She was prescribed oxybutynin by her urologist for bladder urgency. Her primary care physician recently added amitriptyline for the nerve pain in her feet, and she takes an over-the-counter antacid every morning she picked up herself after a conversation with a pharmacist. 3 of those 4 carry anticholinergic activity. Each individual prescriber made a clinically reasonable and defensible decision based on the condition in front of them. No one has reviewed the complete picture. No one has calculated the cumulative cognitive burden she is accumulating from every direction simultaneously. The only symptom she reports is that her mind does not feel as sharp as it used to, which every physician she mentions it to reassures her is completely normal for her age. This is not a hypothetical. This is Vivian. This is your neighbor. This is the person you love. This may be you. Here is your action plan. Write down every single substance you take without exception, every prescription, every over-the-counter product, every supplement, every occasional pain reliever, every sleep aid. Look up each item on the Anticholinergic Cognitive Burden Scale, a free and publicly available research tool that assigns validated risk scores to common medications. Search for it directly online. Schedule a dedicated medication review appointment with your primary care physician using exactly those words. Ask specifically about deprescribing, the intentional and supervised process of tapering medications that are no longer necessary or whose risks have begun to outweigh their benefits. It is a legitimate and growing field within geriatric medicine. If your concerns are dismissed, seek a second opinion without apology or hesitation. A geriatric pharmacist, a recognized clinical specialty, can perform comprehensive medication reviews specifically designed to identify and quantify cumulative cognitive burden. You are not being demanding when you ask these questions. You are being responsible about the organ that makes you who you are. Before you go, I want to hear from you. Which of these 9 medications are you or someone you love currently taking? Have you experienced memory changes, mental fog, or personality shifts that you have never connected to what is in your medicine cabinet? Leave that in the comments. This community is listening. And sometimes the most important thing a person can receive is simply the understanding that what is happening to their mind is not inevitable, not irreversible, and not their fault. If this video gave you something genuinely useful today, please share it. The person who most needs this information is unlikely to search for it independently. You may be the reason they find it. Subscribe to this channel and click the notification bell because I publish evidence-based content designed specifically for adults over 60 every single week. I am Dr. Katherine. Your brain is worth protecting, and now you have exactly the tools to begin.